risk stratifying patients according to their risk of relapse and assigning them to different treatment groups has been one of the underpinning features of the improvement of pediatric acute lymphoblastic leukemia over the past 40 to 50 years. So it's really this risk stratification, along with protocol refinement and better supportive care, that has allowed the outcome of pediatric ALL to improve from around 30% to well over 90% in the space of 50 years. Now, it was very well established very early on that there are some major risk factors in pediatric ALL. Age, sex, and also white cell count have been used to risk stratify patients now for many years. However, in the past 10 years, there's been an explosion in our knowledge of the genetics of acute lymphoblastic leukemia and also our ability to measure the response to therapy. And it is really these two factors, the genetics and the treatment response, that has allowed us to refine risk stratification much more tightly. So there are several genetic abnormalities that are associated with favorable outcomes, such as high hyperdiploidy and ETV6-RUNX1 fusion. And protocols around the world are now beginning to use these two abnormalities to identify patients that are at a low risk of relapse and therefore do not need to receive increasing amounts of intensive chemotherapy. And this represents a shift in the way risk stratification algorithms are being used now. Originally, they were always used to identify high-risk patients, but now they're increasingly being used to identify low-risk patients. The number of genetic abnormalities that are associated with high risk is about 7 or 8. They're the well-known BCR-ABL fusion, patients with KMT2A fusions, patients with near haploidy and low hypodiploidy, the intrachromosomal amplification of chromosome 21, and also the 1719 translocation. And these remain the standard high-risk abnormalities, which will inevitably result in patients being treated at high risk. I've also just mentioned the patients with the ABL class fusions, and of course these will be increasingly added into risk stratification algorithms to ensure that these patients will receive high-risk therapy and also imatinib to help improve their outcome. The other major improvement has been our ability to measure low levels of disease present at the end of induction. And this process, called minimal residual disease or sometimes measurable residual disease, is principally based on detecting low levels of leukemic cells, either using IgTCR, PCR, or flow cytometry, or occasionally specific fusion transcripts. And of course, nowadays, your level of MRD at the end of induction is the principal marker of relapse and is now increasingly used to direct therapy. One of the things that has happened over the past couple of years is people have started to integrate your MRD result, i.e. the amount of disease remaining at the end of induction, and also genetics to refine the risk stratification further. And there are two clear examples here, and these are based around patients with copy number alterations. So these typically affect genes such as Icarus and also CDKN2A. And there have been two groups around the world that have developed copy number alteration risk profiles that have demonstrated very clearly that these risk profiles based on your copy number alteration are modulated by the MRD level as well. So they're applied in conjunction with MRD. And it is really this integration of risk factors that is going to be the future of risk stratification. And hopefully in the years to come, we will be able to integrate even more risk factors into single prognostic indices in order to take this idea further.